Welcome to Hematologic and Immunologic Dysfunction. Production of red blood cells begins by the second week of gestation. White blood cells and platelets begin by 8 weeks. At birth, hematopoiesis or blood cell production occurs in the marrow of every bone. Red blood cells, of course, are the most abundant cell in the blood. At birth, newborns have a natural elevation of red blood cells due to the high levels of erythropoietin, which stimulates red blood cell production. Once oxygen levels in the blood rise, after the baby starts breathing on its own outside the womb, then the erythropoiesis levels go down. White blood cells, you should know, they have a pretty high cell count at birth, but it does vary among babies. There are 5 types of white blood cells, and you can see those above. Platelets, of course, are also manufactured in the marrow. They are stored in the spleen. Some clotting factors require vitamin K for activation, which should be synthesized by the gut. However, a newborn's gut is sterile, so there's no bacteria, so that's why babies get a shot of vitamin K to help them out until their intestine colonizes with normal flora. This is figure 43-1. I really like this figure because it summarizes the clinical symptoms with the type of anemia and possible causes. There's a lot of information in a little bitty graphic. So when I highlight a graphic and stick it on a slide, it's probably pretty important. Anemias can be classified by the causes and physiology, like is it from depletion of red blood cells or hemoglobin or both? And it can be classified by the morphology, such as characteristic changes in red blood cell size, shape, color, or a combination of those. Ultimately, the end result is decreased oxygen carrying capacity of the blood and then decreased amount of available oxygen to the tissues. The diagnostic evaluation for anemia sometimes can be defined as a hemoglobin less than 10 or 11. However, this cutoff may be inappropriate for children due to because hemoglobin levels vary with age. Other tests that may be used would be occult blood, a CBC, a bone marrow test, ferritin, and total iron binding capacity, or TIBC. Consequences of anemia: basically, it's decreased oxygen carrying capacity of the blood, which results in decreased oxygenation to the cells and tissues. The blood viscosity depends on the concentration of red blood cells, so a decrease in the number of red blood cells is going to mean thinner blood and hemodilution. Cyanosis is not usually evident, but it could be there. Growth retardation is typically seen in children due to decreased cellular metabolism and anorexia. This can cause delayed sexual maturity as well. So the therapeutic management of anemia is to treat the underlying cause. We're going to transfuse if the cause is from a previous hemorrhage. We're going to offer nutritional support for nutritional deficiency anemia. We may have to give, in the event of if the anemia is caused from like a hemorrhage, then we may have to give some IV fluids to replace the intravascular volume to support blood pressure and, all the other vital organs. Oxygen therapy, I think you guys understand why, but why bed rest? Children need to rest they need to rest in order to decrease the metabolic demand for oxygen. When you rest your muscles, you decrease your oxygen need. Clinically, they need rest because they feel tired and they fatigue quickly. So usually it's not a huge deal for these kids to lay down and rest. Children need more iron than adults because they have accelerated growth. After 6 months, breast milk and formula do not provide enough iron for a growing baby. They need solid food. Babies are at risk of anemia after 6 months because their iron reserves are usually spent, and if they are not getting the iron that they need from their diet, they tank. Preemies are at higher risk of iron deficiency anemia because they didn't even get to build up a reserve of iron before they were born, because they were born too soon. Recall, it's during the last trimester of pregnancy that babies get a shipment of iron over from mama. If you were born before your shipment arrives, you just don't get that. Thus, children aged 12 to 36 months are at risk of anemia because they also don't eat a lot of iron-rich foods. Most toddlers drink a ton of milk, and milk is really not a good source of iron. Now, teenagers are also at risk for anemia. Um, One, due to their rapid growth, because we all know teenagers have a growth spurt. They Teenagers typically make poor nutritional choices. Females, usually have the onset of their menses, and then obesity and extreme sports can also cause iron deficiency anemia. So the diagnostic labs are listed for you on your slide, as well as the normal hemoglobin levels for the different age groups. Treatment is iron supplementation. Ferrous sulfate drops are given to babies. Um, for children who are able, we want them to eat more leafy green vegetables, fish, liver, and whole grains. Now, what child do you know who actually eats that? Not a lot of kids I know. My children certainly do not. They think they're allergic to lettuce. So we also have iron fortified cereal, and that is really your best source of iron for children. If you think you need to, you can refer them to a nutritionist if you can. If families are eligible, get them on WIC because WIC will provide iron fortified cereal. Babies should be eating iron fortified cereal and formula. Um, and even if they're not on formula, you can still use the breast milk and mix it with iron fortified cereal too. Most cereals, most cereals are fortified with iron, so it's not hard to find iron in a child's diet. Why don't babies who are less than age 1 get cow's milk? I will tell you, because it increases the risk of GI blood loss. Cow's milk contains certain proteins that damage the GI mucosa. Milk is not that great for children. It gets really pushed on kids, but it's really not such a great thing to give. Ideally, we want to give iron on an empty stomach, or we give it with citrus juices for better absorption. We do not like to give iron with dairy products. Why? Because it contains substances that bind with the iron. The dairy products, like milk, contain substances that bind with the iron and prevents absorption from the GI tract. Well, isn't that the whole reason why we're giving iron? So if we give it with something that's going to bind it and prevent absorption, we're really not going to make a difference. We're really not helping our situation at all. It's important to teach parents that the iron may change the stools to like a tarry green. If vomiting and diarrhea occur, you may give it with some food, just not dairy. Um, and again, iron can be fatal if overdosed, so make sure parents have a return demonstration, have them practice drawing up what the correct iron dose is, and really stress to them that this is a med that needs to be kept out of reach of the siblings as well. All right, sickle cell anemia. This is one of a group of diseases called hemoglobinopathies. You can have partial or complete replacement of normal hemoglobin with something called hemoglobin S, as in sickle. Sickle cell diseases include sickle cell anemia, sickle cell C disease, sickle cell hemoglobin E disease, or sickle cell ischemia disease. 9% of African Americans are carriers, which means they carry the sickle cell trait. 40% of Native Africans are carriers. It's pretty easy to do. You have to, if you do a Punnett squared, you guys remember this from like biology before. You make the little, you make a square and then you divide that big square into like 4 small squares. And then you do a big S, little s on the top, and a big S and a little s on the bottom, and then big S means you're fine. Big S means you're a carrier. Little s is going to be the sickle cell. So basically, you have a 25% chance. Carriers generally do not have the symptoms, but the symptoms can flare up when the body is under severe stress, even if you are a carrier. So what happens is on that chromosome chain, there is a substitution of valine for glutamine. When oxygenated, these altered red blood cells have the correct shape, but when they lose their oxygen, it becomes insoluble in the intracellular fluid and crystallizes into a rod-like structure. Clusters of these form polymers that bend the red blood cell. If you look closely at this drawing, you can see how the inside of the normal red blood cell is filled with little round dots of hemoglobin, right? In sickle cell, the abnormal hemoglobin forms strands that bend the hemoglobin, causing the abnormal shape. It's incredible that a single base change causes something that is so profound. One tiny error in a chromosome. And look what we have. A whole classification of diseases. Amazing. So the whole problem with sickle cell anemia is that the abnormal shape of the hemoglobin of the red blood cells alters the abnormal shape, basically clogs up the blood vessels and causes tissue ischemia and damage. This is very painful to endure. Think about it. When people have a heart attack, they complain of extreme chest pain. Why? Because their tissue is experiencing ischemia. So think about think about with sickle cell, this is also going to be very painful because when your vessels are clogged up, even though it's with, hemoglobin and red blood cells as opposed to fatty cholesterol, it's still the end result is still tissue ischemia and damage, and that is painful to endure. The spleen and kidneys are prone to the sickling because the vessels throughout the spleen are very narrow, and the spleen's job is to filter and clean up the blood from the damaged cells. So the manifestations of sickle cell anemia, usually children are asymptomatic until the fetal hemoglobin is gone by 4 to 6 months of age because the sickle cell is inhibited by the fetal hemoglobin. With children with a vaso-occlusive crisis, that means they have the infarct of tissues, the tissue ischemia. I listed out all the different areas of the body that can be affected by that. The brain, it can cause strokes manifested by a headache, aphasia, convulsions, visual changes. As far as the eyes go, you can see retinopathy, retinal detachment, and diminished vision. Bones, you can see chronic ischemia, which makes them susceptible to bone degeneration, infection. Liver leads to enlargement, hepatomegaly, cirrhosis, and scarring. The spleen can cause a splenic infarct, can lead to fibrosis and increased rates of infection. The kidneys, it can cause enuresis, which is like nighttime bedwetting, hematuria, or the inability to concentrate urine. It can cause circulatory obstruction, causing prolonged engorgement of the penis. It can cause peripheral neuropathy of the extremities, as well as weakness and arthralgia. It can cause skin ulcerations. So lots of different ways that these vaso-occlusive crises can affect children. For those who are undergoing splenic sequestration, pooling of the blood in the spleen, that means that they're going to die within hours. Those kids are going to go to the PICU. And then there's something called aplastic crises, profound anemia. This is also life-threatening. And this picture just shows the different clinical features of sickle cell anemia. All right, so the treatment. Newborns are going to be screened for sickle cell disease at birth. The goal of therapy is to prevent sickling and to treat the emergencies of sickle cell crisis. Again, we're telling children to rest. Why do we tell them to rest? Same reason as anemia, to decrease their energy expenditure and improve oxygen utilization. We offer electrolyte replacement because the hypoxia results in metabolic acidosis, which only makes the sickling worse. When the tissues are hypoxic, it's painful. I think I've stressed that a lot. So children need pain medicine for the pain. Usually it's going to be ibuprofen, Tylenol, or Toradol that is typically used. Opiates and stronger pain meds can be used as well. PCA pumps are effective in treating sickle cell crisis too. It is recommended that these children receive pneumococcal and the meningitis vaccines, as well as yearly flu shots because of their decreased immunity due to a poorly functioning or even absent spleen. Now, I will tell you, we used to oxygenate these kids and try and prevent the sickling that occurs from low oxygenation. Now we only use oxygen if there is true hypoxia. Severe hypoxia must be prevented or it can trigger massive systemic sickling, which can be fatal. Oxygen cannot reverse the sickling or reduce the pain because the oxygen can't get inside the sickling cells. So that's why we don't just slap a cannula on kids, just because they have this. Prolonged use of oxygen depresses the bone marrow, which only makes the anemia worse. If you end up doing a blood transfusion, it's usually going to be given early in the crisis and it may reduce the ischemia. It's very important to watch for transfusion reactions. When do transfusion reactions generally occur? Usually within the first 20 minutes. Now, are kids going to be able to verbalize and tell you exactly what they're feeling? Are they going to be able to say a lot of things if they're experiencing a transfusion reaction? Maybe and maybe not. So you're going to have to really just watch them closely because you can't depend on them. They may be young enough that they don't have the vocabulary to tell you what they are feeling, or they may just start crying and say they don't feel good. Either way, you watch kids like a hawk when you're doing a blood transfusion on them. Don't leave them.